Dr. Abdul Salami Nasidi is in his third year as the inaugural director of the National Center for Disease Control within the Nigeria Federal Ministry of Health. He also serves as vice chair of Reach Care Foundation, Nigeria. Dr. Nasidi is a physician with more than 35 years of experience in clinical medicine, public health, virology, and the development of vaccines and biological products. While Dr. Nasidi headed the Federal Vaccine Production Laboratory in Yaba for 7 years, he introduced a new method for the production of yellow fever vaccine, which was used successfully for the control of the 86-87 yellow fever outbreak in Nigeria. He was appointed as the chairman of the Presidential Task Force for Polio Eradication and Routine Immunization in 2008, and his task force developed strategies that have led to the reduction by more than 95% and the virtual elimination of circulating wild poliovirus in Nigeria. He co-developed hepatitis B vaccine and anti-snake venom against the carpet viper and 2 other Nigerian poisonous snakes. He was among 16 people who established the Global Fund to Fight AIDS, TB, and Malaria. Welcome. In Brussels, Belgium, in 2002. He established Nigeria's country coordinating mechanism and served as its chair for 6 years, during which time he oversaw the development of proposals that generated more than $600 million for Nigeria's HIV/AIDS, TB, and malaria programs. Dr. Nasidi headed the Nigerian Health Sector Task Force response to the H1N1 avian flu pandemic and participated in designing the national response to the pandemic. With the outbreak of H1N1, he played an active role in establishing a Nigerian laboratory in Abuja capable of diagnosing the influenza virus, which then became the WHO reference laboratory for the country. He has served on several WHO committees, most recently as Nigerian delegate and vice chair to the Intergovernmental Meeting on Pandemic Influenza Preparedness, sharing the influenza virus and access to vaccines and other benefits. That's quite a title for a program. I'm truly impressed. He participated in the related technical working group for 3 years and served as chair of the technical working group. He has authored more than 50 scientific publications and has been recognized in his country with the National Honor Office of the Order of the Niger. Dr. Nasidi.
Good morning, ladies and gentlemen. I thank you, Dr. Badan, for the warm introduction. I have the pleasure of making myself available to speak with the staff of the Texas A&M, particularly the students. And I must apologize that in case you find me confabulating, this could be due to the jet lag. I've been going through flying, through several countries since the advent of Ebola. The key and what I would like us to do today is not for me to lecture, but to actually exchange experience with you, and also try to move from theory to practice. What you learn and what you see on the ground. From that point of view, my presentation has been made to be more of pictorial and more of graphics than theory. So how do I change this? Ladies? No, I have one here already. As you can see, I'm completely wired. So I have to make sure I'm speaking the truth and not and nothing but the truth. This is the outline of my presentation today. I will try to make it straight to the point. Ebola virus or disease, which is the new name of the disease, EVD, is an acute viral hemorrhagic fever. It is caused by infection with a virus of the genus Ebola virus, one of the most virulent viral diseases known to humankind. It's a severe, often fatal disease in humans and non-human primates, such as monkeys, gorillas, and chimpanzees. Most fatal viral hemorrhagic fever so far recorded. You can see the virus. It's a strange virus identified for the first time to have a filamental structure. It's from the mononegavirales of the group or family of Filoviridae and the genus of Ebola-like viruses. The species is Ebola. I'm sure you know most of this, but it is said by the wise men that repetition is mother of learning. So I just want to take you through, some obvious issues. The genus Ebola virus is one of 3 members of the Filoviridae, and you have 5 distinct species: Bundibugyo Ebola virus, Zaire Ebola virus, Reston Ebola virus, Sudan Ebola virus, and the Thai forest Ebola virus. As you can see, they are all named after where they are discovered for the first time. For a long time, the actual reservoir or the natural host of this virus was not known until of recent that the fruit bats species were found to be most likely be the natural host of the virus. The geographical distribution of these bats, of these fruit bats, is quite wide, but nevertheless, surprisingly, the only places, Ebola virus outbreak, disease outbreak had been recorded had been within the African continent. And as you can see on the African map, the countries that are affected were initially mostly located in the Central African republics, Central African and East African zone of regions of the continent, and of recent, the outbreak appeared in the West African region. These were just some of the key major Ebola outbreaks recorded in the previous years. And the first outbreak was actually recorded in 1976. And between the year 1976 and the year 2012, the cases of Ebola viral disease recorded as compared to what we are seeing now has virtually tripled in just one outbreak in the West African region. How is it transmitted? It is transmitted to people from wild animals, especially bats and non-human primates, and spreads in the human population through human-to-human transmission, through close contact with body or body fluids, and contact with semen. Nosocomial infection in health facilities due to close contact without the use of correct infection control precautions and adequate barrier nursing procedures is very prevalent in virtually all the outbreaks that occurred. In the human body, the blood, saliva, stool and urine, vomitus, sweat, snot, sexual fluids, tears, breast milk are all contagious. Also belonging like linen, clothes, could also be very infectious. This just shows schematically that from the reservoir, you could have a vector, which is intermediate host, to human. And this is the first time a sustained human-to-human transmission outside a health facility is recorded. Thereby, we have combined routes of transmission, rural, urban, and community. That is, in the West African region, we are having the last, extended part of this transmission. And what is very strange is how the virus adapted so quickly to human cells and then became so easily transmissible among humans in urban areas. This never happened before. Who is at risk? Usually people exposed to wild animals or handling them, people depending on wild animals as sources of food, mortuary attendants, health workers caring for Ebola hemorrhagic fever patients, health workers in hospital settings with poor hygiene and sanitation practices. Clinical presentation. Incubation period have been confirmed to be between 2 to 21 days. In most cases, between 5 actually to 14 days. first symptoms and signs appear. What are the signs and symptoms? Sudden onset of fever, intense weakness, muscle pain, headache and sore throat, vomiting, diarrhea, rash or rashes, impaired kidney and liver function, and in some cases, both internal and external bleeding might occur. Possible complications and causes of death. The following have been shown as the main reasons for death: multiple organ failure, severe bleeding, jaundice, delirium, seizures, coma, and shock. Treatment and vaccine. We are all aware that no specific treatment or vaccine is yet available for Ebola hemorrhagic fever or Ebola viral disease. Severe cases usually require intensive support care, and rehydration with intravenous fluids or oral rehydration with solutions containing electrolytes are key to survival. Essential oral medication, oral fluid rehydration, nutrition supplementation, treatment of complications, and psychosocial support are what the patients afflicted by Ebola virus require to survive. Importance of treatment. Ebola virus has been one of the world's most feared pathogens, causing catastrophic clinical disease with high mortality rate. Now easily transmissible from human to human, it makes it really not just a public health emergency, but a serious health security issue. Although the highest priority must be given to public health and infection control measures in the outbreak of Ebola virus, the largest ever recorded outbreak now occurring in the West African region has shown the need for effective treatment. What do I mean by effective treatment? So now having effective treatment as a tool for prevention, just like in the HIV/AIDS. At the initial stage of HIV/AIDS, there was a fight between those who were trying to emphasize treatment and those who were trying to emphasize prevention. But some of us at the level of the Global Fund and the WHO fought that treatment of HIV patient could actually serve as a very effective tool for prevention and also addressing the issue of stigmatization. It worked. Infection control is key because it seems, even though we know so much now about the virus, we know so much about the disease, we don't seem to know yet about the route of transmission. There's still argument whether it is airborne or not. So, in the control and prevention of Ebola viral disease, you need very effective infection control measures. Standard precautions, basic level of infection, good hand hygiene, use of gloves and other protective gear, and of course environmental control measures like clean environment, proper waste management. Prevention, in the absence of treatment and human vaccine, awareness on risk factors of Ebola infection and the protective measures can reduce human infection and death. During Ebola outbreaks, awareness messages should focus on reducing the risk of wildlife to human transmission, e.g. propagating the locusts to avoid eating the games or bushmeat as we call them in Africa, and then of course the human-to-human transmission by educating the masses on how to limit body contacts. When a suspected case is identified, all individuals that had direct contact with the case since the onset of the symptoms are listed using the contact listing form, which I will show you when I tell you the Nigerian story. A competent team are usually designated to follow up all the contacts on daily basis for the next 21 days from the day of last exposure, not the day of first exposure. And thereby, the contact exits the surveillance. Community education is so key. Residents in the affected areas must be taught to avoid high-risk behaviors, including the outbreak, such as bathing or touching the corpses, touching blood or body fluids of sick individuals, reusing injection equipment or needles, sharps, hunting, preparing, or eating the bushmeat. Communities should also be urged to report any suspected case immediately to the nearest health facility or to the command center. Characterizing the outbreak. This is just to show the countries that this outbreak started occurring in the West African region. First cases appeared in December, actually, and the first index case was seen on the 2nd of December 2013, which is a child, aged 2 years, who actually came into contact with bats and the fruit they were eating and developed signs and symptoms of Ebola virus disease. The child was treated by a traditional healer, a famous traditional healer, in this community in Guinea, and the community became frightened when the child died. The traditional healer died. Members of the family of traditional died. Those who participated in the burial acquired the infection, and 50% of them died. So immediately they know something wrong is happening. What can this be? Initially, it was just regarded as strange African hemorrhagic fever. And both the community and the government of Guinea were in denial that this could be Ebola virus, when the first suspicion that this could be Ebola virus came in March 2014. So in the real sense, officially, WHO was notified of this outbreak in March 2014, and immediate laboratory diagnoses were made and confirmed that we are dealing with an outbreak, rural outbreak of Ebola in West Africa, and that being the first official outbreak of Ebola in this sub-region. By maybe just about 2 months, the disease had spread to Sierra Leone, Liberia, and by 18th June, virtually these 3 countries were devastated by the outbreak of this viral infection. Now, it's very important to note that all the previous outbreaks of Ebola had always occurred at one site or in one site. There had never been translocation of the outbreak to other sites. This is the first time that an outbreak of Ebola is exiting the rural area and occurring in several sites within 3 months. You can see that 60 sites became infected immediately. So people now became suspicious. This Ebola virus is unique, is easily adaptable to human cells, and easily transmissible. What type of virus is this? So, despite all these signals, the world did not pay attention to this outbreak. The response was slow, and lagging international response as it stood in August 2014 led to the form of to the fact that now our laxity could lead to between 500,000 to 1 million Ebola infections by January next year. This calculation was based on a model developed by the US CDC and already sending panic to the whole world. So, Ebola virus consolidated in West Africa in 3 countries. Other neighboring countries had no plan, had no response plan to this virus disease in case it appears in their country. Unfortunately, including Nigeria, we had a plan but which we were not ready to activate. And on the 20th of July, 2014, a 40-year-old male, Liberian American, actually, is both nationality, so don't think you are lucky. He was actually to have come to America instead of Nigeria, but he decided to. So on the 20th of July, this 40-year-old Liberian American arrived at Murtala Mohammed International Airport in Lagos from Monrovia via Lomé on Askai airline flight, the number KP50, on his way to Calabar for the 8th ECOWAS retreat of heads of offices for a regional meeting. His plane was reported to have had a brief stop at Accra and Lomé, and the aircraft was changed at Lomé from Ethiopian Airlines to Askai. He was also reported to have fallen ill while on board and remained very ill on arrival at the airport in Lagos on that flight. He was then assisted by various airport and ECOWAS protocol staff to a private hospital named First Consultant Medical Center in Lagos. He was admitted, and investigations were carried out, and supportive treatment commenced immediately. The private hospital immediately notified the State Ministry of Health, who also notified the Federal Ministry of Health. The patient, however, died at about 6:50 a.m. on the 25th of July. The patient presented with a one-day history of fever, vomiting, and diarrhea. At all times, the patient was fully conscious, and he provided history of no contact with anyone suspicious of suffering from Ebola. However, his symptoms persisted despite the supportive treatment. We did not know his intentions. By the time we investigated further, we realized he actually knew that he had contact with somebody that had died from Ebola in Liberia. He was placed on surveillance and was advised not to move out of Monrovia. And at the same time, the person that actually died from Ebola was either his sister or girlfriend. We didn't know the details, but we confirmed he even participated in the burial. So on arrival, his samples were taken, blood and urine sample, and at Lagos University Teaching Hospital NCDC lab, we used what we call the Panfilo diagnostic kits that has the ability to identify any filovirus that causes pathology. So it is a rudimentary test which was available then and which became so useful. And within 24 hours, they picked the signal that yes, the patient had evidence of exposure to an Ebola virus. The next day, we sent the sample to another private laboratory that had PCR, and they used the PCR strain-specific analysis to confirm that, yes, he was actually carrying the Ebola Zaire MGB virus strain. So this singular act shows the importance of local capacity. As compared to the other three countries that had no capacity, the identification of the disease, confirmation of the viral origin of the disease, management and treatment of the disease is all carried out outside those countries' health system. The health system is so weak that they couldn't do anything. So on arrival to Nigeria, with even the rudimentary, elementary, what you will call local capacity to diagnose this viral infection, we at least identified it within 48 hours and immediately instituted our response plan, strategies, to make sure that we're ahead of the virus. Samples, according to the WHO requirements, should be sent to a WHO reference lab, and we did this. An isolation center, that is, immediately we confirmed that we had a case, we had to start putting in place some activities that will lead to first managing patients in case there are any already, since he's dead, and also pursuing the virus, to make sure that the virus does not escape into the community if those who managed him in this private hospital had come into contact with the virus. So some of the few things we started doing was to address case management and infection prevention and control activities. An isolation center was established by the Lagos State Ministry of Health in one of the hospitals in Lagos. We distributed WHO guidelines on how to handle the cases to all health facilities in Lagos. And the private hospital was decontaminated and also prepared on how to continue with their work. Urban Ebola and international health security. Can you imagine if Ebola had consolidated in Lagos? Lagos is a densely populated city with a population of about, well over a midday population of above 21 million, and is therefore huge, and the risk of spreading in this city will have endangered the entire African continent and most likely the world. Investigation of this outbreak revealed that the patient was aware that he was ill at the time he departed Monrovia for Lagos. And he actually informed the ECOWAS representative in Monrovia that he was suffering from malaria. So he knew he was sick. So we didn't know his intentions of coming to Nigeria. Investigations further revealed that the patient lost his sister, what I've told you earlier, and we now instituted an international surveillance activity to confirm what really happened. So, the index case was confirmed on the 23rd July 2014 from Liberia. Nigerian total confirmed case as of today is 19. As of yesterday, 19. Total deaths in Nigeria is 8, and total discharged cases we have is 11. So this is just to show the West African region, areas that are most affected, and from where our index case came from. And also to show that as at 25th of September 2014, Guinea have confirmed cases of 832, total deaths of 635. You can imagine the case fatality rate is so high, above 65%. Liberia has 890 cases and a total death of, so I think 1,000, sorry, total case deaths of 677. Sierra Leone had confirmed case 1,744 and a total death of 597. And Nigeria had 19 cases, total death of 8, 7 confirmed and 1 probable. As of yesterday, the total confirmed cases for the whole outbreak in the 4 or 5 countries is 3,487, and the total number of deaths is 2,917 as of this. So as you can see, we are dealing with a deadly viral infection that unfortunately, in the last 3 weeks, the cases, number of cases is doubling. So there's an upsurge. Actually, there's no interruption of transmission despite all national and international efforts to stop the spread. So the world is now becoming really jittery. And from the analysis conducted by the CDC, cases will continue to double every 3 weeks. And we think by November, number of cases could be in hundreds of thousands. What have we done? We have confirmed that we had Ebola virus infection imported into Nigeria. As the Nigerian president said, he asked us, you said Ebola virus is not airborne, but Ebola virus came to Nigeria by air. So yeah, we told him, yes, it has come by air. It's very fast. We need you to chase it out also by air. So the first thing he did was to establish a presidential steering committee on Ebola virus disease, which really played a key role in mobilizing the country to respond. He declared state of emergency. Federal and state, Lagos state government collaborating in the management of suspected and confirmed cases made a huge difference. A release of 1.9 billion naira, which is about $12 million, to fight the spread of the outbreak was made immediately by the Nigerian government. World Press Conference was held on the 11th of August to inform. So we were not in denial. We accepted it is here and we're going to do something about it. Emergency National Council, on health was held by the Minister of Health to notify all states of this outbreak and sensitize them on what to do. And then we called the attention of the National Security Council. We immediately established what we called the Ebola Emergency Operating Center. This center coordinated all response activities led by the Federal Minister of Health and the Nigerian Center for Disease Control. We had partners, WHO, US CDC, UNICEF, Red Cross, and the Nigerian Field Epidemiological and Training Program. We are very proud we had Nigerian private sector actively participating. So the EEOC was a multi-sectoral, well-coordinated center that led the day-to-day response, on how to be ahead of the virus. So the virus was virtually escaping into the community. We had to develop strategies on how to be ahead of the virus, stop it, and then get it out of Nigeria. So an incident manager was appointed, in the name of Dr. Faisal Shuaib, and then I was appointed the national coordinator for the response. We had daily meetings and established, teams, and appointed team leads. We had case management, epidemiology and surveillance, social mobilization, and points of entry. This is the command structure of the Ebola Emergency Operating Center. This was so key that we held daily meetings. Without having this in place, our response would have been chaotic, would have been disorganized, and we might not have been as effective as we would have liked to be. And this is the only way you can actually get yourself organized to be ahead of the virus. We organized and arranged logistics. We had sufficient logistics to fight the disease. We held sessions daily, and in those sessions, all the partners, as you can see, very active. And we had diagrams of how to follow cases and contacts. It's very clear. From the identification of the contact, we follow through up to the point of informing the case management team if we find any case that has symptoms. And from that, we quickly assemble our, conduct clinical assessment and move straight to getting the patient or the contact that has come out with symptoms into isolation ward. And then this continues until discharge, which you are seeing on the right. That's the green part of the diagram. So with this type of flow, we became very effective and very focused. So the team leads were coordinating. They use the social media, the handsets, and whatever communication gadget, to make sure that they are on top of it. Luckily for us, the Ebola virus does not transmit from a non-symptom patient or contact. So we had windows of opportunity from the time someone comes into contact with the virus, acquires the virus, to the time he becomes infective or he becomes a source of the infection. You have a windows of opportunity. So no transmission were recorded in patients, in those who came into contact with this index case that had no symptoms. But those that had symptoms starting from fever, diarrhea, vomiting in particular, became very transmissible. They transmitted the virus to their closest contacts. So all our secondary contacts, or patients came from the contacts that had, signs and symptoms of Ebola. That helped a lot. And we carried out some of the activities that will enable us and empower us to, one, identify such contacts, two, place them under management, three, prepare the team that will treat them, and also get those teams not to acquire the infection. And I'm happy to announce that even though the Nigerian healthcare workers who acquired the infection from the index case acquired the infection because they didn't know what to do. They knew now that they were dealing with Ebola, but didn't know what to do exactly to be free from Ebola. They acquired the infection. We lost 2 doctors, 2 nurses, and 1, cleaner in the hospital. So it became very obvious that we must now prepare the other healthcare workers that will manage the Nigerian patients who appeared barely 5 to 14 days after contact with the index case. So the EEOC, while waiting for the possible cases to appear, prepared teams and trained them. So as a result, we managed all the secondary, primary contacts that became ill and fell sick with Ebola, and we don't have any Nigerian healthcare worker becoming ill. So which means we did well, we trained our team, and they knew what to do, they managed the patients, and our survival rate was quite high. We had 60% survival rate, which is not bad at all. I mentioned we became also very transparent. We acquired this support from the Nigerian government, who released $12 million to the EEOC, to the team I was leading. After this, I became very popular, you can imagine. But nevertheless, the timeliness of the release was so important that if we had put in all this in place and we had no funds, to conduct the operation, it would have been virtually impossible. Just to mention and show you some key activities of the EEOC, data management. An APInfo-based database was developed and used for follow-up. Data harmonization between the initial Excel and the EPI info databases were instituted and still going on. The e-reporting system via the Android phones is linked to the APInfo database, and this is expected to improve the overall quality of the data management system and facilitated prompt evidence-based decision-making process. The EEOC ran for 24 hours, and until we carry out this analysis, we don't take decision on what to do the next day. Point of entry. So this is another team that was very active. We immediately identified the key points of entry from where people coming from these countries enter Nigeria, and instituted scanning, body scanning mechanisms, developed SOP and flowchart for the public health, port health service staff, then trained 100 public health volunteers, and positioned them in all the ports. Procured or acquired 247 body temperature scanners. Now we have more than 5,000 distributed all over the ports of entry. And then, instituted secondary screening areas, at the largest airport in the country. We assessed public health risk, and land crossing became very, very important for our engagement, because we were initially concentrating on entry by air, but all of a sudden we realized that so many, almost 90% of those who come actually come by road. And what drew our attention was when 3 dead bodies were being brought from these countries. And we now we realized that we might be facing the airports, but the real problem will be coming with the land borders. So we secured the land borders, engaged stakeholders, and conducted a key on-the-job training. On case management and infection control, we established a makeshift treatment center, which is really a semi-abandoned building, because we did not expect that we shall see the first case within 4 or 5 days, as it were. So when we had the first case and our isolation ward wasn't ready, we panicked. So we created, a makeshift isolation ward. It worked. And within 3 days, 3 to 4 days, we had 3 patients. We admitted them here and started managing them. Now, within the same hospital, we have, a well-established, isolation center, but it was to be used for the MDR TB. And some of the patients that we had there that suffered from the MDR were virtually cured and were to be discharged, with the exception of 2. So we recreated another MDR center and moved our patients to this health facility. Why this is important is, if you all remember, it is as if Ebola viral disease is so scaring that all the treatment centers are makeshift in tents and isolated. But we in Nigeria said, no, we can use existing health facilities, and provide better care and, build the confidence of the patients, and that worked. So on the average duration of stay in our Ebola treatment centers, was 11.6 days, the range of 10 to 15 days. Then average age of the patients were 35.9 or just 36 years, and the range of 26 to 58 years. Time interval between onset of symptoms and admission into ETC was 5 to 8 days. So, and average of 3 to 7 days. Currently, I was saying on admission, I should have changed this, we don't have any patient on admission. So this just shows you the modern treatment center we had in Lagos. So when it appeared in Port Harcourt, again, that state, that's River State, was not ready. So they had to rush again to establish a treatment center, and the primary healthcare center was quickly converted. The governor of the state did very well, and we have a fantastic treatment center that the MSF was so impressed. We established effective triage system, and it worked. Social mobilization. I must say this is one of the most important aspects of the fight against Ebola. What did we do? We use mass media, both electronic and print, and to help educate and sensitize our population. We use house-to-house mobilization, sensitization, and hygiene skill education, and also address the issues of mass gathering. Without this, we would have not been able to be ahead of the virus. Social media strategies included dissemination of key messages, clearing rumors and myths, enhancing peer-to-peer behavioral change, communication, and expert discussions of EVD through social media channels supported by Society for Public Health in Nigeria. We dedicated helplines and internet portals. So we had a toll-free EVD helpline, and also we had 48 trained personnel and staff that handled this aspect of the work. We have live chats and handled a website which you see, www.ebolaonline.org. It became so effective and very active. Health worker sensitization was key. We got associations of medical professions in Nigeria to key in, and it was very effective. Laboratory services. We immediately mobilized 4 laboratories. So the Lagos University Teaching Hospital, I told you their role. The Redeemers Hospital, I told you what they did. Then we had the Irua Specialist Hospital in one of the states that was specifically empowered to handle and treat Lassa fever and other hemorrhagic fevers. So we quickly mobilized them, and they were having their mobile laboratory, which was used effectively when Ebola virus escaped to Port Harcourt. Then we have the National NCDC laboratory in Abuja, which played a key role. So this is how we quickly mobilized a laboratory in Port Harcourt. Within 48 hours, we moved the mobile lab, got an NCDC lab that was supposed to be for non-communicable diseases to start working, and then spaces were made available, and we could diagnose Ebola in Port Harcourt without sending the sample to Lagos. Now, as of yesterday, this is epidemic curve of the Ebola viral disease outbreak in Nigeria. As you can see, as from the 3rd of September, we have no cases anymore seen in any of the locations. That means we succeeded to be ahead of the virus. WHO assessed our performance and declared Nigeria EVD free. We showed clearly through this transmission chain how we had most of the cases that we reported in Nigeria coming from the index case, and just very few, as you can see on the right, from emanating as a secondary infection. Okay, so geographical distribution of the EVD cases is shown in this map. For some of you that know Nigeria, you'll see that the few local governments that are mostly affected, were quickly, controlled. This is the epic curve for Port Harcourt, and contacts by date of completion of follow-up is shown clearly here, and that by yesterday we are free. So, we could confirm that we are free of Ebola virus disease. The Lagos profile showing the maps, indicates the local governments. You can see the red dots that were affected, and our duty was to do everything possible to, contain the virus, within the Lagos territory, not allow it to escape. But unfortunately, a belligerent protocol officer, who was one of the protocol officers that met the team that came for the ECOWAS meeting, became ill, even though he was placed by us on surveillance, refused, to heed to our advice. He escaped to Port Harcourt and then took the virus there and contaminated an additional doctor who died, whose pregnant woman wife became infected and was treated, and of course also transmitted the infection to some other people there. So all of a sudden, a deadly virus entered Nigeria and affected the two economically most important cities in the country. Lagos is our economic capital. Port Harcourt on the right, you are seeing is our oil capital. If we had not jumped to control this virus, you can imagine the impact of the outbreak on our economy. So one of the key things that we did to reduce the risk of transmission to the healthcare workers was what I said, the on-the-job training. Then what are other things that actually our response to the Ebola virus introduced? So some of the EEOC innovations. We use what we call the dashboard. And as you can see here, the dashboard is like a system where you check what is supposed to be done, what you have done, and what must follow. Daily, it worked. It made us not to lose any aspect of our response. We didn't ignore activities like online newspaper review, which we do daily. And through it and the management of rumor, we became well equipped to be ahead of the deadly virus. We assisted in organizing the states, sent red alert, told them what to do, and called them to the National Council on Health. Here is just listing all we did to mobilize Nigerian states. What were the steps we carried out as next? We decided to do surveillance strengthening, particularly by empowering the states, enhance active case search within the health facilities. Social mobilization and enlightenment campaigns were intensified, and we also continue to strengthen the point of entry, both land and sea and airport. Because we know, except Ebola is stopped in the 3 countries, no country is free. Not just African countries, no country in the world is free. So lessons learned. This is why I'm here, to share with you. There's no alternative for adequate preparedness. States have to be ready at all times. What will happen if a case was reported today? And this is what we told them. Don't wait. Don't let the virus surprise you. So we told them they should establish isolation centers, establish emergency operation systems. Fear can slow response. In countries where they jumped from denial to fear, they paid dearly for it. Contact tracing is critical and very important. And identifying cases, symptomatic cases, outcome improves dramatically with good clinical care. And by that doing, you also build the confidence of the healthcare workers to respond. I must say that for the first 10 days, no Nigerian doctor agreed to enter the treatment center. They are all frightened. Only myself and one Dr. David Brett Major, an American, who is our hero. He was so great. He actually led the treatment team and saved the life of Nigerians. We owe him a lot. Health policies to guide our direction or direction of health preparedness and response is so key. In Nigeria, we have thousands and thousands of health policies. The problem is the implementation. Also key is the people, the right people to implement your policies. We mobilized, the Nigerian public health team and got the right people to respond. Key is program ownership, country ownership. In other 3 countries, all the programs are run by foreigners, by MSF, by whoever foreign partner comes in to help. So within a short period of time, the locals lost confidence in the treatment team and were rejecting or refusing to go into treatment centers and even refusing the orthodox medicine. Why? When it was investigated, they said, why should we bring our patients into a treatment center managed by foreigners? We bring 100 and you give us 60, 70 dead. So we bring the patients and all we get back is the dead body in body bags. So within a short period of time, they lost confidence. It was difficult to rebuild that confidence. So it's so important to own the program, to lead the program politically and technically, and to establish a well-defined mechanism, such as the EEOC and the incident management system or center that we established in Nigeria. It worked perfectly well. The Ebola crisis was managed in Nigeria. The way we managed the Ebola crisis restored confidence in government at federal, state, and LGA levels. Nigerians were becoming weary and tired of the federal government because of its inability to manage another crisis, which is the Boko Haram crisis, terrorist crisis. But the way we managed and faced the Ebola threat, the confidence in the Nigerian government was rekindled, and then the government became a little bit more courageous, and they are now fighting Boko Haram effectively. Praise the Lord. So presidential commitment and declaration of state emergency timely was so important. The three countries were in denial, refused to admit that this was Ebola. They thought if they admitted it would destroy their economy. That denial cost them so much that now their economy is grounded. They are in state of failure. They can't even pay salaries. Nobody goes to these countries. No airlines go to these countries. We are now fighting to get the humanitarian corridor to open up and get them moving. We are very grateful to President Obama. So we say better late than never. The help came late, but nevertheless now by sending the support, not necessarily the military, but at least the support, we think America is waking up to do something. So the Ebola, private sector before now had no confidence in the public sector, particularly when it comes to funding of our public health activities. But seeing the way we responded to Ebola, that confidence was restored. We did everything jointly, and I'm proud to announce that the private sector contribution now exceeds $10 million. So there is need for continuous training on modern techniques for emergency and disaster control management on the response system, and we believe that paramount importance is also the coordination of our response activities and how to make these activities cost effective. So most importantly, the establishment of the Nigerian Center for Disease Control and its Nigerian Field Epidemiological and Laboratory Training Program, the NFLTEP, has provided us with the key mechanism to face this outbreak. So all of a sudden, everybody saw that for a country to have its National Public Health Institute in place, I'm talking of developing countries, you have so many in your country, but some countries don't even have it. To have one is so important, and that is the arrowhead that led the team that controlled the outbreak. And we are now going to strengthen this system we've established to be ready for any other pandemic. Conclusion: Ebola is a lethal viral infection that knows no border. Early detection and commitment is key. Ebola in an urban Nigeria could be a time bomb if not properly controlled. Ebola is a serious health security issue. In fact, there's fear that the Ebola virus could be handled by the terrorists, but we are lucky that any of them that try it will die first. Every nation, every tier of government, every citizen is a stakeholder in containing the spread of Ebola virus. This was clearly mentioned in the last 3-4 days at the United Nations General Assembly, where special sessions were held on Ebola viral disease. That is very rare. Apart from HIV, I don't know any other smallpox, any other disease that gains such an attention. To be frank, President Obama, I almost said Bush, again, led the Global Health Security meeting yesterday, where all countries, all regions, EU and other organizations in the world made specific pledge to come together to fight Ebola and declare Ebola not an African problem, but a global problem. That we achieved yesterday. So every nation, every tier of government, every citizen is a stakeholder in containing the spread of Ebola, and multi-sectoral, multi-partner response was very effective in Nigeria, and we recommend to every nation. Challenges. I list here some of the challenges, which I'm sure you will read from my presentation, which I'll make available, and also the priority areas I think we should face. welcome to Nigeria. We are ready to, to receive you any day.
We have some time. I want to give you a chance to ask some questions. I first want to acknowledge Dr. Gerkel from the Breach Care Foundation, one of the partners with Dr. Nasidi, who's helped bring, I believe, that 40 students down from Nigeria that are here studying. Probably some of you have some of you in the room. Welcome to you, and you should recognize what an incredible resource the country of Nigeria has in Dr. Nasidi. Every country needs a Dr. Nasidi. So there's a model for some of you to emulate. Questions?
Good afternoon, Dr. Nasidi. My name is Oloy, I'm Nigerian. So, I have some questions actually. First of all, I will say that I'm actually quite glad, even as unfortunate as it is that Ebola came into Nigeria, I'm quite glad that Lagos is the first state it came through, because I honestly think that Lagos is one of the, or at least was at that time, one of the few states that could have was equipped enough to handle the Ebola outbreak. Well, now my question is this: you said in your slide that other states, are being prepared or have been told to prepare for any emergencies like this. Okay, so my question is this: is there any follow-up to ensure that these things are being done? How is it being enforced? Are there penalties for states that do not enforce or do not put these things in place? Okay, and then also second question is about stigmatization. What is being done to address the stigmatization of patients that have recovered, their families? Because I've heard of a case where a girl who's from Liberia, leaving Nigeria, committed suicide because of all the stigmatization that was going on during I think that was in the month of August when the Ebola outbreaks happened. So what is being done to prevent cases like this? And third question.
Well, thank you very much. What is your name again? Okay, I will tell the president of Nigeria that you are happy that Ebola came to Nigeria. Well, I know what you mean. It served as a stimuli to, getting government response to public health and enhanced funding. I'm not particularly glad, but I too, indirectly, I'm glad that at least there's now attention to public health, and all government instruments that address funding, budget, are all looking for me. How much do you need? How much do you need? Praise the Lord. Yeah. So it's not that it's something that you should celebrate, but nevertheless, it has served as a stimuli. On stigma, you are right. We used the media, the health education, particularly communication, to reach the people and explain, what will happen. That if somebody is declared, to be Ebola-free, is healed, then definitely he doesn't have the virus. He doesn't serve as a source of infection. But the clinics and hospitals where, Ebola virus, EVD patients, pass through. I have such slides, but I thought it would be too long to show. Is when some of the healthcare workers that came into contact with the index case started experiencing temperature and some signs. We actually, 1 week arrived, the second day to that hospital, we talked to them, told them what to do, and gave them a protocol and said, please let us know here our telephone numbers, call us if there's any sign of and symptom. And many of them responded positively. Some became frightened and were in denial. In fact, the primary consultant that saw the patient was in denial, and she paid dearly for it because she died. She came late. So some of them decided not to call us, went to private clinics and private hospitals. And then, when they found out that they were not, being managed properly there, they now were forced to call us. So all such clinics were stigmatized. Nobody went to them, nobody wanted to go to them until of recent. And one of the ways of addressing the stigma was we got the governor of the state, we got ministers and also to invite the survivors, mingle with them, eat with them, and then that opened up, or address a little bit some of the issues of stigmatization. The public became relaxed. On issue of follow-up, we have the EEOC is having 24-hour service, and as I'm talking to you now, all the activities we listed that must be carried out, we have a dashboard which we follow. So that EEOC has the mechanism to follow what is happening in the states, and all the states that are dragging, we are looking for one way or the other to help them. So that's my answer.
Yes.
Thank you for taking time to come out today to speak. My question is, how receptive and feasible is it for the surrounding countries to replicate the model that Nigeria undertook for preventive measures, especially considering, for example, Sierra Leone took a completely different approach by isolating and establishing a curfew?
The issue of, replicating what Nigeria has done, we're having a lot from the African Union, from the ECOWAS Health Organization, and we call it WAHO, West African Health Organization, a request that Nigeria should assist the other neighboring countries on establishing similar systems. The Nigerian president has directed that we should move to Liberia and all the affected countries. As I'm talking to you, we have 538 volunteers that have signed to move in there and support. So I'm sure by next week we should be on the field. So we're going to form response mechanisms as we have done in Nigeria. And we also have the West African Health Organization actually identifying the Nigerian Center for Disease Control to lead the technical working group that will respond to this outbreak. So that's another achievement. The issue of curfew arose from the fact that, from denial to reality. All countries that denied, the outbreak, particularly, Liberia, paid dearly by encouraging the appearance of Ebola virus disease in the community. And the moment you have community transmission, it's easier to contain rural transmission. It's a little bit more difficult to contain urban transmission if you do exactly what we say you should do. But when it goes into community, where culture and religion will fuel the transmission and explosion of the outbreak, it becomes more and more difficult. They lost out, the community panicked, and you heard about killings. So this is one. And two, you have the collateral effect of Ebola. As I'm talking to you, these countries have lost out to other diseases. HIV, AIDS, malaria, nobody's talking about them. All the health treatment centers do nothing except Ebola. Their hospital occupancy is far, far below what they need now. In Liberia, they have less than 1/10 of the hospital bed occupancy availability. For instance, they have 358 beds available. You can imagine. So no health system. And now for Ebola alone, as at last week, they needed 1,571. Yesterday, I was talking to somebody in New York who just came from, he told me, Dr. Nasidi, we need now 3,200 bed, to care for the so it's tripling. So that's why, Sierra Leone said, oh, listen, we can't cope. What's really happening? So if people die because of the panic, and knowing quite well that now transmission is higher from dead bodies to the humans, they don't handle the dead bodies anymore. So people throw the dead bodies to the street. So the director of US CDC went to Liberia about 3 weeks ago and was shocked. I think people say he had tears in his eyes. When he saw dead bodies on the street, people were running away from dead bodies. They couldn't bury their own next of kin. That's how bad it was. So the curfew was to test run a military approach to see what will happen. So you are aware that following that curfew, within 24 hours, they identified 92 dead bodies abandoned within the communities, which they had to take and then really bury. So this is what led to the declaration of not now state of emergency anymore, but curfew. running down the country, to make sure that you could, match the virus and, if possible, stop its transmission. Okay.
My question, the first comment is that it's true that Nigeria is Ebola free, and we pray and hope that it will be Ebola free for God knows when. But my question is that if we become Ebola free for months and years, there's a possibility that all the efforts you're talking about at the port of entry and everything, that there's a likelihood that efforts will calm down and people won't pay too much attention to it. So what efforts are you making to make sure that these efforts are consistent and things that are supposed to be done are done? And also for funds, it was when Ebola came up, that was when the government released funds for emergency response to Ebola. What efforts are you making to have continuous funds available in case we have outbreak of any other disease in the future?
Your question is all around sustainability. And that's why I said institutionalizing, public health response is key. So the establishment of the Nigerian Center for Disease Control, as NCDC, will now, make the government channel, funding of public health activities to a particular agency. So we think this is one of the sustainability mechanisms that will help us, not to relent and go complacent. And if we do that, we are going to pay dearly for it. So we are now discussing with the National Assembly on, enhanced budgeting to NCDC and other public health. They are all of a sudden, for almost 35 years I've been in public health, I've been fighting to convince the Nigerian government that you are spending too much on, care and treatment aspect of medicine and ignoring prevention. You will one day pay dearly for it. It didn't occur until when I've actually retired and I was called back to come and establish this. And this is occurring when I'm around again. So the National Assembly is now calling me to say, yeah, you are right. Now what should be the ratio? Before it was 70% to care and support, 30% to public health. Now I think if we are lucky, we might make it 50-50 or even more. So that will address your question.
I would just interrupt the question just a minute. Jerry, I'm afraid you might be leaving, and I wanted to give you a minute just to talk about the vaccine center and how that factors into the larger discussion of today's topic. Just give us 2 minutes.
I'll do, but I want to preface first by saying your country and actually the global community owes you a big thanks. And actually you're a shining light of inspiration. And this is maybe also for all of us public health students, and I count myself as one of those, that overnight, this is an example of how all of a sudden public health is thrust into the front line. And your leadership in being thrust into the front line of a crisis is very inspirational. And the global community does owe you big thanks.
Thank you very much.
And I was glad to see one of your bullets up there that, because I think the community has thought that Ebola from 1976 until the current could be managed just through infection control, isolation, and so forth, and that was the case. But you did have a bullet up there that said that we do need treatments, and treatments would be helpful. And one of the things that actually we are working, hope we get a chance to talk some more while you're here. One of the things that we are working here at Texas A&M through the Center for Innovation and Advanced Development and Manufacturing is providing new capabilities for developing vaccines, therapeutics, and we are hoping to be involved very soon in helping you in that endeavor to accelerate the development of some promising Ebola vaccine candidates and some very promising Ebola therapeutics, to include some of the monoclonal antibodies that everybody's well aware of. But those are some things that we're beginning to work on, and I think everybody in this room would be interested, because I think more and more they're going to be playing a much more critical role in global health threats like Ebola, but there are other threats, like you mentioned, that are actually causing more disease today than Ebola. But we got to deal with Ebola. But I do have one question that I do want to put to you. And first, I think the West was a little slow off the start in responding to the outbreak in West Africa, and before your country was affected. And the NGO community and countries were asking for help and saying that this is a far worse outbreak than what was being reported. The West and the United States in particular is recently, I think, moving forward to provide more assistance and help. But I guess my question is, from your perspective, what is the best way that we can help? What is going to be most useful? And because there's ways that we can help shape the policy discussion and making sure that we can help calibrate the assistance that would come from the West and the United States in particular. So your thoughts and ideas, and we can talk more about this later, but I'd like to see your first gut reaction of how we could be most useful.
Well, I thank you for acknowledging the Nigerian response, and at the same time, thank you for the good job people are doing on vaccines and therapies. If you ask which way do you think will be the best strategy, for intervening, before now, from the time the affected countries were crying that we're in crisis, including the presidents, virtually declaring that the whole country has failed. A country president announced that we have failed, come to help. Nobody came. The help came very late, and it came slowly. That was a disaster for humanity. But nevertheless, we are now responding. So what we have seen, from the experience of these countries and what we've shown from Nigeria is that local capacities are so important. Existing local capacities are so important. And I showed clearly that even though we're the first laboratory that identified the virus within 24 hours, used the most rudimentary technique to just show that, hey, listen, we have a signal that there is evidence that there is a filovirus in this patient. Even if it's not yet confirmed, was enough trigger, strong trigger, to move us to start responding. We didn't wait for the confirmation, even though we went for it, and we did it within 48 hours again, still using our local capacity. So we announced at the UN General Assembly that there's no way you will address the issue of Ebola viral disease outbreak, containment, or containment of the spread, without addressing the issue of short-term, medium-term, and long-term. And any organization that comes only with short-term strategy, we tell them you don't really mean well. If you mean well, you must have long-term strategy. So the short-term strategy to us is to quickly help us with the medications, prevention tools, especially we have the vaccine candidates. We have some drugs that are candidates that could be effective and which had undergone phase 1 trials. So the countries affected, particularly the neighboring countries, would be most happy to see that the West has come to help and that there are pledges for those products. Then, the next most important to us is training, building capacity. And, the hospital bed capacity, is something that goes side by side with providing, enhanced care and support for the patients. But we say that can actually can be handled by the African countries. For instance, the Nigerian government made available $3.5 million for the affected countries. I heard he wants to make much more money available so that at least they can build, and expand their hospital capacity. We are very happy again that U.S. government is making available 10,000 bed capacity. So this is, the immediate that moves into the medium-term support. Now, the medium-term support we are requesting is, assisting the region, even if not all countries, to establish, a national public or regional public health institute that will be in position at least to respond to any sub-regional or regional this thing, because virtually, as I said, all the 3 countries, as I'm talking to you now, all the response activities are carried out from outside. They don't have any capacity to face this challenge, unfortunately. So if we can have NPHIs, like the Nigerian Center for Disease Control, in 1 or 2 more places, and at the same time, get support to establish, to assist us to establish what we call the African Center for Disease Control, which the AU has agreed that should come up, will work. Finally, we think the long-term strategy must include our ability to produce what we need to fight the disease. Collaborate with good establishments like yours to address the issues of drug development and manufacturing, even if it is through shared manufacturing strategy, and also talk about vaccines. How do we collaborate? We can collaborate by sharing with you our materials. We either send you the samples or we send you the sequences of the virus, which we have now. And that means we share the material and share the benefit. So these are long-term strategies we believe we want to, we've put forward. And at yesterday's meeting, I think all the major donors, the major countries have accepted. So these are my answers,
I think we have the foundation of a good collaboration.
Yeah, and actually, this I must say that our collaboration between Nigeria and Texas A&M has now come to be justified by saying that all the states we talk to are now emphasizing public health training, and I have, as I'm talking to you today, additional 5 states that want to send students to Texas A&M. Dr. Durfa here, who is my boss, is one handling all this. I'm sure you will soon start seeing more and more Nigerians here.
Very good, thank you.
One or two more questions. Yes. Hey, thank you for speaking on. I'm Eric Wilkelly with the Brazos County. Nigeria had a lower fatality rate than the surrounding countries. I don't know if you identified any clinical interventions that you think may have contributed to the lower case fatality rate.
Yeah, well, as I said, first and foremost, the mechanism put in place by the EEOC, the Emergency Operating Center, to identify the patients early played a key role. You understand what I'm trying to say? We realized that some of the countries affected, most of those who died, have the following. 1, they came late. 2, they are older. 3, they have comorbidities, like diabetes and so on and so forth. So we now said we shall fail if we actually, don't go for that and get quickly the surveillance team to identify those who come early with the symptoms, into the isolation centers. Then, the next, within the treatment center, what we observed was that the first patients that came in were healthcare workers, doctors, and nurses. So all of them knew that the major pathology in Ebola virus disease is enteropathy and encephalopathy. So the enteropathy leads into dehydration, severe dehydration, and the consequences. So when I go, I realized that, as part of the treatment, they were actually consuming. There's one that was having more than 20 liters a day of just drinking and drinking and drinking. And he was very severe. We thought we were going to lose him. He survived. So rehydration and electrolyte replacement played a very key role, in our patients surviving. And of course, the last thing is within 10 days, we now have battalion of Nigerian doctors and healthcare workers who are ready to move in to support. So that helped a lot. So they were having hour by hour, attention, follow up, and actually the few that died, in the early days. But the subsequent days, virtually we saved all. Yeah.
Was your hydration mostly oral rehydration, or was there intravenous hydration?
Yeah, both. those who were subconscious or not in the state, we did the IV. But those who were conscious, we decided not to disturb them, not to invade and get the virus out of their blood. We allowed them to do oral rehydration. One thing that shocked me is the Nigerian patients did not show much of hemorrhage. Okay, so what really killed them was the severe enteropathy and some of them the encephalopathy. So in that case, some of the few that I saw was confirming that the disease is biphasic. In the first few days, it is mostly enteropathy, and then they improve, but the virus continues multiplying in the organs, particularly the brain. So you see, the third, fourth day, the patient is better. You come, you are happy, he's sitting. You say, this has survived. Then the next day you come, he's subconscious, he's in coma. And he goes brain dead, and that's it. So it's a deadly disease. So in fact, that's the first time I was frightened. And, so if I acquire the virus, I don't know if I will survive. I was never afraid initial time, but when I saw 2 patients dying this way, it frightened me.
I think we're through. We could stay here for hours, I know. I would love to hear more, but we're going to let Dr. Nasidi rest a little bit. As you know, we flew in late last night from these meetings in New York, and it's a little worn out. Again, just thank you so much for your contribution and for being our friend.